Hello, and thank you for joining our June webinar. My name is Ellen Johnston, Program Manager of Risk and Coding Accuracy at Mount Carmel Health Partners, and I will be your host for today's webinar. We are excited to dive into this month's topic, chronic obstructive pulmonary disease and other lung conditions, but first I'd like to cover some details. Health Partners is providing a small incentive for your time and attention today. In order to receive your payment, we ask that you watch this presentation in its entirety by August 21st, 2020, fill out the webinar attestation in W-9, and return to Health Partners no later than August 21st. If you have questions throughout today's presentation, please feel free to contact myself or Dr. Bennett through our contact information listed at the end of the presentation. Now, let's get started. Our webinar today is entitled Risk Adjustment Documentation and Coding Tips for COPD and Other Lung Conditions. Our featured speaker today will be Dr. Paul Bennett. Dr. Bennett is a physician liaison with Health Partners and board certified in family medicine. He retired from his practice in Grove City in 2018 after 12 years. Prior to that, he was a primary care physician in Southern California for 24 years. He was in practice with a strong managed care focus with risk contracts. Welcome, Dr. Bennett.
Thank you, Ellen. It's a pleasure to be here to discuss this topic with you today. Before we start discussing the specifics of COPD, let's review some of the risk adjustment essentials. Risk adjustment is the methodology by which CMS determines how to adequately allocate resources to Medicare Advantage plans for patient care. There are many factors that determine resource allocation, both demographic and clinical. Demographic examples include patient age, patient gender, institutional status, Medicaid status, and the reason for being Medicare eligible. Clinical factors include chronic conditions that have been shown in CMS data to require more resources. This data comes from the diagnosis codes you and other providers submit. As you know, there are 70,000 diagnosis codes in the ICD-10. Every year, each code is evaluated using CMS data to determine which codes utilize the most resources. Once that's done, the data is normalized so that the average Medicare Advantage patient has a risk score of 1.0. Around 9,500 of the diagnosis codes are determined to affect risk, and they each map to what is called a hierarchical condition category, or an HCC. An HCC is a group of chronic condition diagnoses that are clinically similar and have been determined to have a similar effect on resource utilization. Each HCC has a weight, and these weights are what calculate the clinical portion of a patient's risk score. There are 86 HCCs that are included in the 2020 risk adjustment model. For a diagnosis code to be captured on the claim, it must have supporting documentation within the record. An easy way to remember documentation requirements is the acronym MEET, which stands for Monitor, Evaluate, Assess, and Treat. Only one of these elements needs to be present for each diagnosis that is taken into medical decision-making during each visit. For example, discussing how the patient is doing on current medications, reviewing spirometry results, referring to a pulmonary specialist, and adjusting medications all meet appropriate documentation requirements. As telehealth is becoming more frequently used in Medicare Advantage population due to COVID-19, it's important to note which modes of telehealth communication are acceptable for risk adjustment and closing HCC gaps. In order for a telehealth visit to be eligible for risk adjustment, the visit must take place with real-time audio and video capabilities by an approved provider for risk adjustment, such as an MD, DO, PA, or CNP. Most importantly, it must be documented in the medical record that the visit was completed over telehealth with synchronous or real-time audio and video services used. Documenting this in the medical record will keep the visit compliant with CMS when capturing and closing HCC gaps throughout the year. Next, we will jump into information specific to COPD and asthma. This is the WHO diagnosis of COPD. I think we all would agree it's fairly broad, but accurate. When you add the criteria that the FEV over FVC is less than 0.7, you add the measure that distinguishes it from milder forms of chronic bronchitis or emphysema. The risk factors are listed. As you see, exposure to indoor and outdoor air pollution, occupational dust and fumes. Chiefly, it's exposure to tobacco smoke, either active smoking or secondhand smoke. And some cases of COPD arise from long-term asthma, and then it develops into severe enough for chronic COPD. Another easily accessible practice guideline from AAFP is in the reference slide at the end. Here we see the definition for asthma. The defining characteristic of asthma is that it is reversible. Chiefly that between attacks of asthma, the patient is normal, or even the spirometry may be normal. You can see here the risk factors are family history, allergies, obesity, and symptoms can include wheezing, frequent cough, and shortness of breath. But once again, the chief distinguishing characteristic for asthma is that it is reversible. Between attacks, the person may be normal. Another easily accessible practice guide from AAFP is in the references slide at the end. Now let's look at some of the details regarding documentation and coding for COPD, asthma, and other lung conditions. The ICD-10 code category for COPD is J44, other chronic obstructive pulmonary disease. There are separate codes for COPD with lower respiratory tract infection, acute exacerbation, as well as unspecified. If known, be sure to document if a lower respiratory infection is present, as well as what type of infection. If an acute exacerbation is present, be sure to note this as well, and use the J44.1 code, COPD with acute exacerbation. J45 is the ICD code for asthma. There are many codes available to properly describe the asthma that the patient is experiencing. One key documentation point to include in the medical record is if the asthma is intermittent or persistent. It is also best practice to document the severity of the asthma if known, mild, moderate, or severe, and if an exacerbation or status asthmaticus are present. On the next slide, we will review a diagram that aims at clarifying the different types of asthma codes that are available for use. To choose an appropriate asthma code for your patient's scenario, start with the maroon oval J45 written in it. Next, does the patient have mild, intermittent, mild persistent, moderate, or severe asthma? Choose the correct 10th digit to add to the J45. Following that, is there an acute exacerbation or status, asthmaticus, or is the asthma uncomplicated? Choose the correct 100th digit to add to your J45 code. At the end of this equation, you should have a complete and accurate asthma code to use to diagnose your patient. For example, if the patient has mild, intermittent asthma with no complications, the correct code would be J45.20. If the severity is unknown and there are no complications, J45.909 can be used for this scenario. J41 is the ICD-10 code category for chronic bronchitis. Documenting for chronic bronchitis includes details such as if the bronchitis is simple, mucopurulent, or both. If the bronchitis is considered obstructive, be sure to make a note of this as well and use a code from category J44 instead of J41. Once again, the decision to diagnose one code or the other by the provider is based on the severity of symptoms, and the correct ICD-10 code should be used based on what is documented. J43 is the category for emphysema. There are many choices for different locations of the emphysema, so documenting the type of emphysema, if known, is important. Sometimes lung conditions may be present together. On the next slide, we will discuss how to handle scenarios where a patient has more than one lung condition present at the same time. We have been discussing the differences between these diagnoses, but also when the severity of the diagnosis is enough, they can be coded together. As you can see above, we have COPD and emphysema together. You use J43.9 if the patient does not have chronic bronchitis. However, if the patient has COPD, chronic bronchitis, and emphysema, use J44.9. And if a person has both COPD and asthma, use J44 and J45 together. It is important to document any current or historical tobacco use that the patient has, since this can be a huge risk factor with any lung condition. There are multiple codes that can be used as necessary depending on the patient's tobacco use. These codes are not risk adjustable, but they can be important for data collection and telling an accurate patient story. Tobacco use and tobacco dependence should be used when the patient is currently using nicotine. Tobacco use means the patient occasionally uses nicotine products, and dependence means the patient regularly uses nicotine products. For example, a patient who smokes 1 pack of cigarettes a day and has been doing so for years. Now, Ellen will review some documentation scenarios that demonstrate some of the material we covered today.
Mr. James is a 78-year-old male who presents for his chronic follow-up. The provider reviews Mr. James's COPD symptoms and documents that his symptoms are worsening, which is one way the COPD is supported in the documentation. In the assessment and plan, the provider also documents that a change to Mr. James's medication will be made to try and alleviate his symptoms. This is another example of proper supporting documentation for the patient's COPD. The appropriate code to use would be J44.9 COPD unspecified. In this example, the provider is seeing Ms. Smith. She has COPD and her asthma has been noted as moderate. These conditions have been well controlled in the past on LABA/LAMA. After discussing with the patient about her symptoms, the provider notes in the medical record that her wheezing has increased as well as shortness of breath. Evaluation of symptoms is one way that the COPD and asthma are supported in the documentation. In the assessment and plans, the provider adds a long-lasting ICS, which shows the treatment plans for the diagnoses were taken into account, which is an element of MEAT. There are 2 elements of supporting documentation in this record, which is great. The correct ICD-10 diagnosis codes to use in this scenario would be J44.9, COPD unspecified, and J45.40, moderate asthma uncomplicated. The patient in this last example has asthma that is noted in the medical record by the provider as mild and intermittent. The patient is in the office today for a cough and congestion that has turned into persistent wheezing. The provider discusses the patient's symptoms, and the status update of the acute exacerbation getting worse would be enough to support the diagnosis of mild intermittent asthma with exacerbation. The provider also states in the assessment plan that a Medrol dose pack and Pulmicort will be prescribed, which is also supporting documentation for the asthma diagnosis. The correct code to use in this scenario would be J45.21, mild intermittent asthma with acute exacerbation.
To summarize our presentation today, we have 3 key takeaways to review. First, when documenting for COPD, always make note of any acute exacerbation or lower respiratory infection the patient has. Document and code what type of infection is present if known. You choose your code for COPD from the J44 series. Secondly, when documenting for emphysema, always document the type if known, such as panlobular, centrilobular, etc. Chronic bronchitis should be described as simple, mucopurulent, or mixed, and an appropriate J41 code used. If it is considered obstructive, this should be documented and coded using the selection from category J44. Lastly, we document the severity of asthma if known, and if it is intermittent or persistent. Any acute exacerbation or status asthmaticus should be noted and coded as well. Below are the references that were used for the information presented for anyone interested. And I particularly take note of the last 2 references, which are the EASY guidelines and are very helpful in coding and obviously in treatment. There will be no webinar opportunity in July, and we will pick up in August with our topic of vascular disease, and in September, we will be covering neoplasms. Thank you for attending and listening to our presentation today. Please return the attestation document and the W-9 included in the email to Ellen Johnson by August 21st of 2020 if you are interested in the incentive. If you have any questions about the content, please feel free to reach out to any of the contacts listed on this slide. We hope you learned a little bit more about documenting and coding for COPD and other lung conditions and are able to apply this knowledge into your everyday practice.